Continuing with the process of endometrial biopsy, now let us see the video of endometrial biopsy.
The endometrium is the inside lining of the uterus. An endometrial biopsy is the removal of a sample of tissue from the endometrium for testing. A biopsy may be done to screen for cancer or precancerous cells, to determine the cause of irregular bleeding, or to investigate fertility problems. This procedure can also check for infections and monitor the effectiveness of certain medications. An endometrial biopsy can be done in your doctor's office in 10 to 15 minutes without the use of a sedative. Your doctor will first do a manual exam to determine the position of your uterus, and then place a speculum in your vagina to open it up and keep it open so the cervix is visible. Your doctor may use another instrument called a tenaculum to grasp the cervix and hold it steady during the procedure. Your doctor will then pass a long, thin, flexible tube called a pipelle through your vagina and cervix and into your uterus. The pipelle is equipped with a piston-like device that creates suction when pulled. Your doctor will spin the pipelle and move it up and down in the uterus while suctioning up an adequate sample of endometrial tissue. Then remove the pipelle and place its contents in a container. Your doctor will complete the procedure by removing the tenaculum and speculum. After the biopsy, some patients are able to sit up immediately and feel minimal cramping. Others, who may feel some dizziness, will be asked to lie still for about 10 to 15 minutes before being released. An anti-inflammatory medication, such as ibuprofen or naproxen, is often prescribed to minimize any menstrual-like cramping or discomfort. Your doctor will send the sample to the lab for testing. Results may be given to you by telephone or during a follow-up appointment with your physician.
I hope the video is quite clear about the procedure of endometrial biopsy. Now, what is the post-operative period? Patient may have light spotting and some abdominal cramping. So light spotting we can ignore if it is there for a few days, but for cramping one can give analgesics. And patient has to have abstinence for at least till the bleeding stops. And like for DNC, again nothing to be introduced inside the vagina like typos, etc. So if this procedure, if we don't get a proper report of histopathology, which is usually in the form of polyp, fibroid, endometritis or endometrial cancer, or sometimes it may be a normal report. If the report is inconclusive, then either one has to go for a DNC or hysteroscopic. Better one should go for a hysteroscopic guided biopsy. Because in what happens in endometrial biopsy, it's only a random sample which we are taken, and sometimes we may miss if there is any cancerous growth or any other abnormality. So even if the after endometrial biopsy, if the symptoms don't go, it is better to go for a hysteroscopic guided biopsy. So a few more terms as far as the DNC and endometrial biopsy is concerned. One of them is fractional curettage, which was being done earlier, but nowadays very few people do it. Indication is abdominal uterine bleeding in perimenopausal and postmenopausal women. Here the main purpose is to diagnose endometrial and endocervical malignancy, and it helps in staging of endometrial carcinoma to some extent and helps to decide extent of surgery in endometrial carcinoma. So the steps are almost similar to the dilatation and curettage, except that after doing pervaginal examination and introducing the speculum and tenaculum, first the endocervical curettage is done, and that is labeled as sample 1. Thereafter, the uterine sound is introduced to measure the length of the cavity. Then the dilatation of the cervix is done, and then the uterine cavity is curetted, which is labeled as sample 2. In earlier days, one used to do, even at the isthmus, one sample used to be taken, and all the four walls, that is anterior, posterior and lateral walls, the curettage was done, and 6 samples were labeled. So sample 1 and sample 2 material collected is separately and labeled and sent for histopathological examination. And as I said earlier regarding the isthmus, the study of isthmal sample does not alter the management in the case of endometrial carcinoma. So and it better one should do a hysteroscopically guided endometrial biopsy is superior to the blind curettage. And extent of the surgery is to be decided according to the state of the malignancy and the pathological grading. Few words about the hysteroscopic guided endometrial biopsy. Whether the DNC endometrial biopsy or a fractional curettage, all are like blind procedure. One cannot see the endometrium or the sample which we have taken, and sometimes the abnormal tissue can be missed. So that's why hysteroscopic and guided biopsy is needed when there is a recurrence of bleeding after endometrial biopsy, and this would be ideal procedure unless TBS shows the presence of a definite growth, in which case the procedure can lead to dissemination of the tumor cells. And hysteroscopy is very effective in identifying a hitherto undiagnosed submucous fibroid or polyp and in removing them. So this was about the DNC endometrial biopsy and related procedure. Now we'll go for the tests to assess tubal patency. The various tests which are enumerated below, like dilatation and insufflation test, hysterosalpingography, which is more commonly being done nowadays, then saline infusion sonography, hysterosalpingo contrast sonography, sonohysterosalpingography, laparoscopy and chromoperturbation, falloposcopy, and salpingoscopy. We'll be dealing with hysterosalpingography in detail later, but other procedures we'll be explaining in brief. So dilatation and insufflation, or DNI, nowadays is not being done. Earlier, before the advent of even hysterosalpingography, this procedure was done. Here the dilatation of the uterus is done and introduction of air or carbon dioxide into the uterine cavity, which once it is pumped into the uterine cavity and through the Rubens cannula, the diagram being shown on the side, and then you hear with a stethoscope for the sound. So indication is to note the tubal patency for the investigation of infertility and following the tuboplasty operation. So positive test, how do we know? It is by the hearing of the hissing sound audible in the flanks when you put a stethoscope in the flanks. And there is a drop in the manometer reading if the tubes are patent, and patient complains of shoulder pain on sitting or due to irritation of the diaphragm by air. So there is various tests for tubal patency, and the significance we'll be dealing with shortly, and later on we'll be dealing with little detail. So hysterosalpingography, it's which is an injection of radio-opaque dye into the uterus following X-rays and fluoroscopy. Significance is that they're performed in follicular phase, can visualize uterine septum, polyps, hydrosalpinx, and site of the tubal block. It is contraindicated in active bleeding and has got a high sensitivity for diagnosing tubal block. Saline infusion sonography, there is an injection of saline into the uterine cavity, and significance is that is a test for tubal patency and differentiates endometrial polyp from submucous fibroid. And transvaginal ultrasonography can diagnose tubal block, polyp, and the subtate uterus. The falloposcopy is a flexible microendoscopy of the tube performed along with the hysteroscopy. Here there is a visualization of the tubal lumen. Tubal cannulation can be done under guidance and not routinely used for tubal patency and hydrosalpinx. Laparoscopy, of course, there is a visualization of various structures of the inner genital organs, that are the tubes. We can see the condition of the fimbria, tubal block, hydrosalpinx, peritubal adhesions. Then the ovaries, if there is any abnormality like polycystic ovaries, endometriotic cyst, adhesions, tubo-ovarian mass, and sometimes the evidence of tuberculosis and pelvic inflammatory disease is seen. And in the uterus, we can diagnose myomas and uterine anomalies, which is seen by the exterior of the genital organs, and the peritoneal factors, endometriotic deposits in the pouch of Douglas, and adhesions are visualized. Let us discuss some of these procedures in little detail. The sonosalpingography, it's a safe and practical method of evaluating tubal patency. It's done under ultrasound scanning. The slow and deliberate injection of about 200 milliliter of physiological saline is done via a Foley's catheter. The inflated bulb of the Foley's catheter lies above the internal os and thus prevents the leakage of the saline. And while doing the sonosalpingography, it's possible to visualize the flow of saline in real time along the tube and observe it issuing out as a shower at the fimbrial end if the tubes are patent. So ultrasound also shows the presence of free fluid in the pouch of Douglas if the tubes are patent. As a good technique, also good techniques for detecting submucous fibroid polyp and other intrauterine lesions. And the next is laparoscopic chromoperturbation. It's a visualization of the pelvic structures, uterus, fallopian tubes, and ovaries. And methylene blue is injected through the cervix to visualize the spill of the dye through the fimbria, as can be seen in this picture. And it is indicated in laparoscopic is indicated in infertility cases to establish patency of the fallopian tubes and to verify the findings when hysterosalpingography has shown blocked tubes. And besides that, one can see peritubal adhesions and any unsuspected endometriosis. That is the advantage of laparoscopic chromoperturbation. So what are the indications of laparoscopy? Hysterosalpingography showing abnormal findings. It's prior to planning for puboplasty, prior to intrauterine insemination, prior to induction of ovulation, and for the removal of hydrosalpinx prior to IVF, and PCOS to puncture the cyst, and some suspected cases of endometriosis. If these cases are there, then laparoscopy is beneficial. Coming to other methods, not routinely used, but just for the sake of enumerating. One is hysteroscopy and phalloscopy. And the hysterosalpingography shows a corneal block, which may be due to tubal spasm. However, in HSG, it can be avoided by prior atropine injection, or if there is a mucus or inspissated material, polyp, synecdoche, or ismica nodosa, interstitial end of the fallopian tube is best studied by phalloscopy or hysteroscope. This one can see the phalloscope going through the ostia and into the fallopian tube. The next one is ampullary and fimbrial salpingoscopy. This can be utilized to study the mucosa of the fallopian tube, to choose the tubal microsurgery and IVF whether it's required. And it's a descending test. So here we can see this thing for salpingoscope being introduced to the fimbrial end of the fallopian tube. So a descending test can be done with the salpingoscope, in which the used starch is injected into the pouch of Douglas, and the presence of starch in the cervical mucus 24 hours later indicates the patency of one or both the fallopian tubes. Another method is Hysterosalpingo contrast sonography, that is HyCosy. Hysterosalpingo contrast sonography, usually shortened to HyCosy, is a safe and reliable outpatient ultrasound procedure. It's used to investigate infertility, looking at the cavity of the uterus and then the fallopian tubes. Uterine cavity is measured first. A contrast agent is injected into the uterus, and if the tubes are not blocked, then the agent can be seen passing through the fallopian tube using ultrasound.